Back to Practice has been made possible with support from Allergan, Novartis, and Notal Vision. We'd like to thank our sponsors for their support of this programming.
Welcome back to Practice, New Retina Radio. And tonight we have three wonderful guests, and we're going to be talking about two main subjects on tonight's podcast. We're going to be talking about telemedicine and how it's impacting our patients, how we're using it during COVID-19. And then we're going to talk about combating patient information. And joining me tonight, we have some really great guests. We have Judy Kim, who is a professor of ophthalmology at the Medical College of Wisconsin in Milwaukee, Wisconsin. And we have Byron Ladd, who is a former Bloomberg Award winner and a partner at the Virginia Eye Institute in Virginia. And we have Carl Regillo, the chief of the retina service at the Wills Eye Hospital and professor of ophthalmology at the Thomas Jefferson University in Philadelphia. Thank you all for joining me. I'm John Kitchens with Retina Associates of Kentucky in Lexington, Kentucky. Today is September 29th, 2020. And worldwide, we have 33.5 million cases of COVID with just over 1 million deaths. And in the United States, we have 7.1 million cases with 205,000 deaths. So Judy, let's start with you and just find out, how are things in Milwaukee?
So Wisconsin is one of the states with increasing COVID positivity, and most of it is actually due to college having opened up, and one of the top 10 cities of highest incidence is La Crosse, unfortunately, and that's where one of the University of Wisconsin campus is located. So I think, we were doing really well, and we still have enough capacity, fortunately, and the positivity rate is going up. But fortunately, I think during this time, we have learned how to take care of our patients better in the ICU and in the inpatient units. So the morbidity and mortality seems to be more manageable.
Judy, are they changing anything from a societal standpoint that's making it more difficult for patients to come in and see you?
Actually, not. We haven't had too much problem, except it has nothing to do with the pandemic, but more of the social injustice with the protests and riots. So one of our city, about 40 minutes south of Milwaukee, was affected during the protests, and some of my patients, many patients who come from there, felt a little uneasy about coming or felt somewhat despondent. So making a point of talking to each and every one of them when they come in, not just regarding their eyes, but also their mental state, how they're doing, making sure they're not depressed or stressed out. We're all stressed out, but making sure they're managing well, and answer any questions that may have besides their eyes, but more about how to handle and live in this new world.
That's a great point, and we will talk a lot about that in the last part of this. Byron, you're in Richmond, Virginia. How are things in Richmond?
Richmond, we're pretty much back to full speed. The rate incidence of COVID has been pretty flat. We've had some outbreaks in some of the colleges, but as far as our practice goes, we're back to 110%. We cut down 50% during the early phases, at least in the retina group. I'm in a multi-specialty group, so we have a lot of general ophthalmologists, but the general ophthalmologists dropped down to about 10% of their usual schedule. We maintained about 50% so that we could stay open for patients that needed treatment. And now, we were shut down for about 8 weeks, and now we're back up full speed, 110%, trying to catch up for patients that delayed their treatment and for patients that have continued to need it.
And you're in a unique position, being in a multi-specialty group. Are your general ophthalmologists back up to full speed as well?
Pretty much, yeah. They are back up to full speed. Surprisingly, we're seeing the older patients. They want to get their cataract surgeries done. They want to get their glasses. They put off getting glasses, and now they're coming in to even get glasses and cataract surgery. So our general ophthalmologists are back up to 100% also.
And did you see patients who couldn't find a way to see you when your anterior segment guys were shut down or limited? Did you see some vision loss because of that? Patients who may have put off a detachment and whatnot?
Yeah, absolutely. I mean, from retinal detachments that had persisted for a month to patients that converted in their other eye, or a new conversion. They might have dry macular degeneration and converted during the epidemic. They come in with a decline in vision, and now we're trying to get them back. Maybe we had them maintained on every 3-month intervals, and now we're treating them monthly to try to regain as much vision as we can because of the delay.
And Carl, in Philadelphia, you guys have really been almost a gold standard for an East Coast city, doing so well. Are you continuing to do really well?
Yeah, we are doing well. We were hit moderately hard early on when the peak of the crisis, late March, April, May, when virtually everything was shut down. Our practice wasn't shut down, though. Of course, we kept seeing patients. But as you know, New York City and New Jersey got hit really hard. And in our practice, which is based in around the Philadelphia metropolitan area, we cover South Jersey. So we were definitely affected in that way. And it was pretty bad. Our patient volume was down to about 25% during those 2 to 3 months when things were peaking in the Northeast. And I guess you would say still the main peak of the United States. We are, I would say, for the most part, back to our usual numbers. We've made lots of changes and accommodations to keep patients spread out in time and space, of course, to keep everyone safe. We're still in that mode. Of course, we have to be. But I'm actually not sure I'm seeing all our patients back, because I'd say on any given day, 10, 12 of my patients that I might see are patients that have been rescheduled that were 6 or 12-month follow-ups from that time when we were rescheduling patients. Because, of course, during the peak of the pandemic, we were rescheduling all the non-essential, non-urgent cases and or examinations, encounters. And we're now catching up with that. So I'm not 110%. I'm probably 100% of my usual volume, but that means some patients are still probably not quite making it back.
And you guys have a lot of offices, Carl. Do you guys see regional variability with,
Yes.
Really? How is that? Do you see it lowered rates in New Jersey and higher, patients who show in Philadelphia?
Sort of as a extension of what Judy said, the urban environment got hit the worst. One, because the numbers were the greatest there, and two, patients were afraid to come to the city. One, during COVID, and also with some unrest more recently for obviously different reasons. But nonetheless, as you know, we're sort of hub and spoke. Wills is sort of central. We have all these satellites, north, west, east, and south, into South Jersey and into Delaware. The further you went away from the city, I think there was less impact. First of all, COVID wasn't as prevalent. So people weren't quite as afraid, perhaps. I would say in general, elderly everywhere were afraid for good reason. The ones that were most vulnerable, the patients, the people at risk. And, that was an accurate perception. It wasn't just a misconception that, they're at risk. They were. But now people are feeling more comfortable. We've had a very good track record, and I try to convey that to reinforce patients to want to keep coming in on a regular basis so that we don't lose them again. As Byron mentioned, we all have our anecdotes of patients that were lost to follow-up or had delay in care. We're even now, one of our fellows is putting together data that clearly show patients that presented with retinal detachment, we had a much higher percentage of patients that were MAC off compared to the same time frame last year or the year before. And so we know patients were coming in late, just like our cardiology colleagues were showing that patients were having their MIs at home and not going to the hospital because they were afraid.
So Carl,
that's really interesting, Carl, because even today I had a full day of clinic, and I had 3 patients. I mean, I thought I was already caught up.
We're not caught up.
All my rescheduled patients, but they show up and I'm like, where have you been? Why didn't you come back? One said he got hospitalized in between. I mean, these are elderly patients, so they get sick too, in addition to being afraid of coming in. And then I find that, well, your edema is worse now. We have to start all over again.
Yeah, I think if we don't get a true second wave, I think it's going to take me another 6 months to truly get caught up. One, for the patients that missed visits or were rescheduled during the peak. And two, as Byron said, sort of catching up on care that sort of got out of control. It wasn't well controlled, we'll say. And now we got to get the wet AMD or the DME back under control with more frequent treatments, more frequent visits.
How do we avoid this going forward, Carl?
Well, hopefully we, as a society, we continue to exercise all the precautions. We're certainly doing that locally in our offices. We're stressing, in fact, office manager emails are going out regularly, stressing to our staff to, hey, please be careful out there. So, we want to protect ourselves, our patients, everyone. We have to all do the right thing. So, of course, adhering to the guidelines, continuing to wear masks, continuing with sterilization or protocols to keep the environment clean, doing all that for, I think, for quite a ways to come. Patients will say, I'll see you in the spring, maybe we won't be wearing masks then. And I say, well, I wouldn't probably say spring, maybe next summer or so, because, by the time we get immunization truly out there in society, it's going to take, many months to roll out. We're going to be well into 2021 before things, I think, resemble true normality.
So, Byron, you use the 4C home device, home monitoring for your patients. What kind of role does it play in this pandemic?
Yeah, so I have been using the device for several years. I think I was an early adopter just because I was close to the headquarters and was able to meet with the representatives from NOTAL early on. And I think in this pandemic, it's been very important because the patients have this sense of security that even though they can't make it in for their regular visit, that they're being monitored. And I've seen that even before the pandemic. You tell somebody they have macular degeneration and their first thought is they're going to go blind. But then you can reassure them with this device that they can participate in their care. And by utilizing the device, the study shows that 95% of the time we'll pick them up with visions better than 20/40. And you compare that to, iris registry data where we're getting them around 20/80, it's much better. So, giving patients the tools that they can use so that they can self-test at home in a more sensitive and accurate fashion than just using the Amsler grid, I have found has been very important for the patients. And the patients through the pandemic that come in, I feel less concerned for them. And I wish that I had a larger percentage of my patients on the device, particularly through the pandemic.
Can our older patient population use this device easily, or is it something, it seems very technologically advanced? Is it something they struggle with?
Well, I think, most of our elderly population are pretty advanced technologically. And, they're using computers, they're using iPads and Kindles to read with. That's my most popular low vision recommendation is to start using a Kindle. But so if they use a smartphone or a computer, they can use the device. It's no more than just utilizing the mouse to click on the lines as it flashes in front of you. They usually complain that they move too fast, but unfortunately that's part of the requirement of the testing. But they do very well. And, 75, I asked earlier in the last couple of weeks what retention I've had, and 75% of the patients that I refer for the device end up using the device. Some of them, decide not to from the get-go, and others have trouble establishing a baseline. But for the most part, it's well received.
So, Judy, you're an advocate for this home monitoring as well. Tell us, what can someone who's not using the 4C, what are some take-home things that they could know about this to make them feel more confident or more knowledgeable in using it?
Well, I'm an advocate because I was one of the investigators in the home study that allowed approval of the 4C home. And there are many clinical trials. All of us have participated in investigator as a clinical trialists. But this is one study where we actually had to stop the study early because there was a clear benefit of using the 4C home monitoring versus the Amsler grid alone. So I think having been a part of the investigation process makes me, and knowing the data and so forth, makes me a believer of it. On the other hand, I do think that it is more for patients who are highly motivated, who want to be engaged and be empowered about their eye care, and who are a little more aware of what needs to be done. So it's not for everyone, but for some patients who are motivated, or they have already lost vision in one eye and they want to keep their other eye very well monitored, or someone who says, "Doctor, what can I do? What else can I do to make sure I could catch this early?" As Byron said, if we catch it early, we can keep that vision for good vision for a longer period of time. So I tell the patient, this machine will catch it earlier with less vision loss and more likely to have 20/40 vision. And that will allow you to keep driving and keep reading. And when patients start using it, I'm actually quite surprised at how compliant they are. And some people actually get hooked on it, and they use almost every day. And I have some patients, snowbirds, who carry it from snowy, cold tundra of Wisconsin to Florida or Arizona or Texas, wherever they go for winter, because it's portable. It's small enough, and all you need is just plug it into an outlet. You don't need any special equipment. And the 4C Home Data Monitoring Center, they are very in tune with how the patients are doing. And they provide all the help that's needed to set up and to continue. And there's a lot of dialogue going with the patients who are using it. So as a physician, I wish more patients were on it. I wish more doctors were prescribing it, because even during this pandemic, I have actually caught some patients through the alert at earlier stage of conversion, which I don't think I would have caught if we weren't using 4C Home device for that patient.
And Carl, is it a substitute for an examination in this era of COVID? Is it something that you would put your patient on, and instead of seeing them back in 6 months, you'd see them back maybe in 12 months because they have concerns about COVID, and this will alert you, or is likely to alert you if they have an issue?
So I wouldn't call it a substitute. We wouldn't have data to support making that claim. But as Judy said, I can echo, I wish I had more patients on it. I do have patients on it. It is great technology, as Judy and Byron have mentioned, proven to catch the transformation of dry to wet earlier when the vision is better. And we published, and other groups have published, when you catch wet AMD when the vision is 20/40 or better, you can keep them 20/40 or better over 80% of the time out through 2 years or more. That's a powerful, powerful statistic, because early intervention with our drugs, we get great results. And I think those patients are also less likely to see atrophy when you catch them early when the lesion is small. That being said, about COVID, I wish during COVID I had more patients on it. And I do think patients probably would have been safer on it in having their examination or their encounter delayed for whatever reason, whether it's they're in the hospital or medical reasons. But during COVID, yeah, they were 2, 3, 4 months beyond their 4-6 month checkup, and I still want to see them. I still want to get an OCT, and a few other points about the use. It is time intensive relatively for a patient. It takes 3 to 4 minutes per eye, so patients have to be aware of that going into it. Otherwise, you can lose them to disuse of the device. So you want to keep the compliance going. And they have to be 20/60 or better in an eye. And even when they are, about 20% of the time, they don't establish a baseline, so they can't use it going forward. But we still have a lot of patients that could be on it, should be on it, and would benefit from it. And now with COVID and trying to minimize office trips and trying to keep everyone safe, it is really great technology for this setting.
No, we have multiple companies that are bringing forth home OCT. Is that going to be a substitute for this? Is it going to replace the home monitoring, or do you think there's still a role for home monitoring when we do have home OCT?
Well, home OCT, in fact, the versions I know of, and they're probably going to roll out initially as an adjunct or a way to help us monitor our patients' response to wet AMD therapy. They're not necessarily at first going to be utilized, although they could be utilized to try to catch dry to wet transformation. It is possible that in the future they could replace the 4C technology if you had a patient with dry AMD use it. And of course, the patient that you're managing one eye and is dry in the fellow eye, that patient's probably going to be scanning both eyes. So in effect, they'll be following themselves. SD-OCT is a great way, of course, a very highly accurate way to detect neovascular transformation early on. So it could, but we have a lot to learn there. I think right now it's about whether we do a treat and extend approach or a PRN approach with therapeutics that are on the horizon that are lasting longer. It is going to allow us to have patients go longer and longer without having to come into the office.
Judy, you had a comment?
Yeah, I think initially it will be FDA approved for eyes that already have wet AMD and start the anti-VEGF therapy, and then it will be used as monitoring that eye. But as Carl said, if the second eye is intermediate AMD, there's no reason why you can't do it and then catch the conversion earlier. I think the beauty of home OCT is that all the retina specialists know SD-OCT so well, and the way it's going to be set up is going to be interactive. So we as physicians could look at the OCT of the patient when they do it at home. So it's a truly telemedicine where they're imaging at home, but the physician can look at that OCT as well in the office and be able to know whether there's truly fluid or not. And also another way that physician can interact is that we can set the bar, the threshold where the alert can go off. So depending on our each individual retina specialist's comfort level and also how the patients have responded over time, you can set a certain level for Mrs. Jones, another level for Mr. Johnson. I think it is truly a way of personalizing and individualizing for each eye even, not just the person. So I think there's a lot more interaction, even though it uses automatic artificial intelligence analysis. I think the physician has also a lot more control over what is considered a threshold and need to come in. So even if the alert goes off, we could actually, as a physician, look at the OCT before telling the patient to come in, which is different than a 4C home where if there's an alert, we usually just have the patient come in.
Yeah, that would really make it nice for true telemedicine, where you can then get on, something like Zoom and talk to the patient directly. Byron, last question on this subject. Home monitoring and home OCT, are they competitive technologies or complementary technologies?
Well, I think as Judy and Carl explained, they're going to be used differently. One's going to be used for screening the patients with the 4C home device that are intermediate AMD patients, and then the others for our patients that are being treated. I think that the nice thing about home OCT will be it will get rid of a lot of the frustrations that the patients have with the current home monitoring, that having to test, taking 3 minutes per eye, the line moves so fast that they feel that they're not seeing it, was there a bump there or not? Those are the common complaints that you hear from the patients. And the home OCT being automated and relatively having no interaction with the patient except for them looking at the scanner will make it much easier on the patients. But as of now, they'll be complementary. One will be used for screening and the other will be used for monitoring once they've undergone treatment.
Fantastic. Let's move on to patient misinformation. Byron, I'm going to come back to you. Are you experiencing a lot of patient misinformation in your clinic?
Well, I mean, I think what are we referring to as misinformation? If you talk to, like, is it safe to come to the clinic? That kind of information. I think that our patients, initially were very concerned, and then once they saw all the protocols that we had in place, they felt very safe coming to the clinic. We were having them wait in their cars. We were cleaning every room. We weren't having them move between other rooms. We keep them in one room, so there was less contact. So I think that the patients felt very safe that they could come to the office. Now, of course, we're not in a hospital setting. They may feel a little more concerned about heading towards a hospital than a community-based practice. But other than that, I mean, as far as what other types of misinformation
Well, just misinformation about COVID itself, concerns that they could catch it through their eyes, that, that there could be greater risk by coming to see you. And then also, how are you getting this message out to those patients? Is it through Facebook? Is it through your website about the protocols and safety that you're taking? Right.
So basically on the phone calls, as we schedule these patients and bring them back in, they do have a lot of questions about what we're doing to lower their risk. And so we have long conversations, my staff, much longer phone calls than just scheduling, explaining to them what the experience is going to be like. During the early part of the pandemic, we spent so much time rescheduling patients, one, just trying to figure out who should come in and who shouldn't, and then explaining to the ones who are coming in what measures we're taking and that we feel that it's important, for them to come in. And what I was surprised with is how important we are to our patients. I mean, I always kind of took it for granted, that we're just doing our job. But during this phase where, they felt their life was truly at risk, they were coming in for their eye care. I mean, I had more than one 90-year-old lady tell me she'd rather die of COVID than lose more vision. And so they kept coming, even though they'd have to quarantine for 2 weeks when they get back to their nursing home. It reinforced the importance of what we're doing for our patients.
Byron brings up a great point, and Carl, I'd like to get your thoughts on this. We are oftentimes the most frequent physician that our patients see. They're coming in for every 4 or 6 week injections. We get to know our patients. We have conversations with them. Are they asking you things about COVID?
Oh, sure. And as Byron said, these patients coming in knowing that the doctors, the staff are putting themselves at risk. We're on the front line here. They're highly appreciative of what we're doing and being there for them. I can't tell you how many thanks I got from patients that just said, thanks for being here. Thanks for being open. Thanks for, seeing me and keeping me seeing. I have to say, I'm going to look back fondly on a job well done, because our experience was favorable in the sense that we've had no problems. We took all the precautions that were necessary, followed all the guidelines from the very beginning, and I'm not aware of, knock on wood, any problems related to COVID, either outside source putting it in the office or us giving it to our patients. And so, and as Byron mentioned, we used all avenues to get it out there to patients, to make them comfortable so that they could come in and feel safe on our website, signage, on the phone with the patients, especially those, of course, that kept rescheduling on their own as opposed to us rescheduling them, just reassuring them that we've created a safe environment. And we got through it. We got through it well, and we've made adjustments that will probably carry on, efficiencies and so forth. Our wait times are a lot less. We're much more conscious of it. Our staff, we all work better as a team in getting patients in and out, because no one wants to be waiting and then start to have congregations occurring of patients, and that again increases the risk. And so I think we've taken away some lessons learned and better ways to practice in the future, and we'll carry on, including attention to infectious diseases. It could be just the flu season, whatever that's going to be in the future, the next bug that comes around after we get beyond COVID. Public health awareness in general is going to be better in the United States, worldwide, and certainly in healthcare.
Carl, do you think we'll be wearing masks going forward?
Until we're truly over COVID, we'll have masks on, of course. I don't think we're going to necessarily, it's probably going to be intermittent, selective, whether it be flu season or whatever. Some have brought up some concerns. You try to solve one problem, you create another. Unfortunately, I had a post-injection endophthalmitis case just recently, so it's fresh in my mind. And everyone's wearing masks. Our patients wear masks. We tape it because we don't want to get airflow and oral and nasal flora up in their eyes, and yet it still occurred. We can't eliminate these problems, and we certainly don't want the use of masks to introduce new problems. Some people claim it may increase the risk of oral flora in the eyes, for example. So we're doing everything to try to prevent that. So I'm not sure it's necessary or even beneficial to wear the mask if you don't have to.
Gotcha. And Judy, what is your role in kind of dealing with some of these COVID-19 controversies, talking to patients about COVID-19, ensuring that our patients have a good understanding of how to be healthy?
Well, I think we do it by example. Even from the beginning, when we call the patient to remind them about their appointment and talking about COVID symptoms, we have the callers have the script, but that educates them about different symptoms that they should be looking out for. And then when they come to the hospital, again, they are asked about these symptoms. And then, while in the office, I make additional efforts visibly by sanitize my hands multiple times, a lot more times than I used to, right in front of them to show that it's important. I'm a Johns Hopkins graduate. We never wore scrubs outside of the OR. It was not looked upon favorably, but during this pandemic, I'm wearing scrubs. And in certain ways, to me, it's sort of like armoring myself, putting my uniform on for that day's battle, because it is sort of like a battle. We never know when the next patient may have that COVID. So and my hair's tied up. So the patients who have been seeing me for a long time, they know that I'm already looking and behaving differently, more cautious. So I think we do it by example, and tell them, mask is not a political statement. It is not about freedom. It is about health. I mean, I remember going to a store in the beginning around April, and a gentleman in his late 60s or early 70s looked at me and said, "You shouldn't be covering up your pretty face with a mask." I mean, it's wrong in so many different ways.
That's so wrong in so many different ways.
It's so wrong in so many different ways. But I looked at him right in the eye and said, "This, sir, is to protect you." And that is what masks are. It's to protect my patient, and they are to protect me and my staff. We're in it all together. So I sometimes feel like I'm playing a cheerleader role, and saying, we can do this, this will pass, we can do it together. And I also find that many of my elderly patients are just by themselves. The kids are not even visiting, or they drop the groceries off in front of their door. They don't come into the house. So they're lonely. Many of them are by themselves. Their spouses have passed or whatnot. One of my patients said, Dr. Kim, I think I could speak cat language now, because only living thing that I can talk to is my cat. And other patients say, Dr. Kim, coming to the Eye Institute is my event of the month or event of the 2 months, because they are not going out anywhere except to come to get their injections. So, and many of them have, all have masks on, so it's hard to read their emotions as well. And many of them have a hard time hearing, so I have to enunciate what I say and talk more slowly and loudly so they can hear. So some of the things I'm being additionally mindful, given this COVID era with the masks and other things and social situations. So I try to make their visit worthwhile by trying to reaching out emotionally and psychologically as well as ophthalmologically.
That's a really beautiful point, Judy. The fact that our elderly patients, don't get to see people. We may be the only person that they see on a month-to-month basis. And I find that being able to sometimes stop and realize, hey, wait a second, I need to spend more than 3 or 4 minutes with this person. I know I'm in a hurry. I know I'm behind, but this might be their only time out until they see me again next month. It's very, very profound.
Hey, John, I have a question for the group. How many have adopted gloves for every patient exam? Is everybody doing that?
Yeah.
I do not, but for depressed eye examination where I'm actually touching, that's the only time when I'm putting the gloves on and the injection. But for a regular slit lamp, I have not, but I just sanitize like crazy before and after.
That's a great question, Byron.
I keep debating it, and I always make sure that the patient sees me put the hand sanitizer on as soon as I go to the exam. And I always use gloves for the injections, but for the exam, I have not started wearing gloves for every exam.
So, Carl, you're the one person amongst us that's doing it. Why do you think that makes a difference?
Well, I'm not sure it makes a difference because so before COVID, of course, I didn't wear gloves for anything, not even an injection. Of course, I used sterilizing solutions before and after touching any patient and before and after any injection or any procedure. So it was probably adequate unto itself, just that. And then I got super compulsive about it during COVID, and noticed that most of my partners were wearing gloves, and then I decided I'm going to start doing that too. One, because it was commonplace in other environments, and I think it helps to remind us all to be a little more careful right now. I'm not saying it's sort of like the notion of a mask sort of preventing people from touching their face. This is in a way a constant reminder for me that there's a problem, and I need to make sure I adhere to the highest standards of cleanliness as possible. Not all doctors necessarily change the gloves with every patient. They'll sterilize the gloves, so it's effectively like not having them. But I think it helps, and perception is very important, as Byron mentioned, that it's important for the patient to see. And I'll take on and off my gloves in front of the patient and sterilize again. They want to see it. Patients will often ask when they come in a room, "Has this been cleaned?" And of course we said yes, but it is more comforting to actually see it being cleaned and know it's being cleaned. Because for example, as things start to open up, I'll mainly, maybe I'll go to an outdoor cafe now, and I'm, doing the same thing as my patients. I'm holding my hands up, wondering, I hope someone cleaned this because I didn't see it happen. Yes. By the way, for masks, I'm sure all our offices have strict mask wearing policies. We do. And we have sort of guidelines as to what acceptable masks are not, and making sure both nose and mouth are covered. In every office, we have to designate an enforcer, because occasionally you'll have a patient that comes in and refuses to cover completely or cover adequately. And it can get contentious. And so we have, whoever is most adept at negotiations and speaking with patients to be called upon to stress the reason why. And like has been mentioned, this is not a political thing. It's to keep everyone as safe as possible. So we'll be doing this for a while. There's no doubt about it, until things really are well behind us with this COVID-19.
I can't wait to find out who the Wills Eye Institute enforcer is.
At Wills Eye, it's a rather large man. It is truly like a bouncer. In the other offices, it's whoever's most skillful at persuasion.
Perfect. Well, listen, I want to thank you all for joining me. This has been a great panel, a lot of fun. I want you all to stay safe, and I want to thank everyone for tuning in to New Retina Radio, Back to Practice. Look forward to more episodes as we go forward. Thank you, guys.
Back to Practice has been made possible with support from Allergan, Novartis, and Notal Vision. We'd like to thank our sponsors for their support of this programming. This webcast podcast is intended solely for ophthalmic healthcare professionals and ophthalmic industry representatives. By accessing this webcast podcast, I acknowledge that Bryn Mawr Communications LLC, herein BMC, along with all third-party corporate supporters of this webcast podcast, makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information presented in this webcast podcast. BMC, along with any all third-party corporate supporters of this webcast podcast, do not endorse, approve, recommend, or certify any of the opinions or information presented or mentioned. BMC expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or other damages arising out of any individual's use of, reference to, reliance on in this webcast podcast.